Hello and welcome once again to Minds That Matter. I'm your host, James Thomas. And with us today is the mental health advocate for the state of Rhode Island with an impending reappointment coming up, Mr. Cosper.
Thank you very much.
Great to have you here.
Thanks, same here. It's nice to be here.
Well, it's what, the second or third time that we've had you on the show.
I think it's my third.
But we want to remind the viewers of what is the role of the mental health advocate. We'll start with that, and then we'll work our way through.
All right. Well, we date from 1976, 75, when every state got a mandate to end institutional level care. Mm-hmm. And so for the first 15 years of our existence, we were involved in facilitating the reduction of long-term care from asylum care mm-hmm. To the point where the hospital is was about 98% empty, and once that was successfully in place, it became our statute. We turned our attention to issues of quality of life in the community and neglect of people who require a higher level of care who are living in dumpsters and require a higher level of mm-hmm. care than they're getting from the mental health system. So that's kind of a 30-year capsule of what we do.
Okay. Now we talked a long time ago. I've been here 27 years. And when we started out with deinstitutionalization, there were 500 people or so at Eleanor Slater Hospital, used to be called the IMH. Right. And a lot of folks came out. Right. But there are also a lot of folks now that are at the ACI who has significant mental health issues. Right. I call it trans-institutionalization, right. where people have been transferred from the old IMH, Eleanor Slater, but now they're being housed by the ACI. And I'm just concerned about the fact that we've seen this phenomenon, and at least this is the way I'm observing it, and I'm not sure what your take is on that.
Well, that word, trans-institutionalization, is the word that's used in the literature, mm-hmm. and it's a sad development. And Rhode Island is among the states that is heavily responsible. We've done a really bad job on that, and that's kind of at the risk of taking too much time. What we did in Rhode Island was we created a community-based mental health system from nothing, mm-hmm. and we did it really well. We did regional mental health centers that were globally funded with a fixed set of responsibilities, which is kind of how universal health care should be organized. And so by 1981, if you lived in Rhode Island with a serious mental illness, you needed one phone number to get a full array of services: psychiatry, doctor, social worker, housing, address your needs. And that's unlike other states. Mm-hmm. And we were very, very successful at it. The hospital actually went from 75, it was like 3,800 patients. And when it was down to 500, I think when you came on board, it was down to 200 and change in 1991. And now it's down to less than 100. Mm-hmm. And among the early things I griped about when I got my job was that we were, at that point, sending mentally ill people to jail. And the jail now has 4 times more patients than the hospital has, 4 times more mentally ill people than the hospital has. And we were in the blessed position of, we created a very good mental health system, and so the way to address the problem of trans-institutional care is to tweak that system a little. Just simply create a bridge from the prison to the hospital and use the bridges from the hospital to community, and our mental health leadership failed us in that era.
There is no bridge.
There is no bridge.
No.
In fact, there's kind of this: leave me alone, or he's responsible.
If you need mental health care, you go to the forensic unit from the ACI.
And that's only if you're really, really, really psychotic.
Right, and there's 20 beds.
Right, but in general, people with mental illness in the prison, they sit in the general population, they take their medicine, they vegetate, they live withdrawn lives, they have residual symptoms, and they're discharged with more or less a bag of clothes and bus fare.
Mm-hmm. To a shelter.
Yes. And if we're being listened to by the big shots in the bureaucracy, it's true that they've made glacial and tiny changes in this. We now allocate $100,000 a year for discharge planning, but it's kind of like it's outside of the mental health system, so it's catch as catch. In a way, it's not well spent money, because this should be happening. It's happening from an institution called a jail. It should be happening from an institution called a long-term care center, and it should be integrated into the global mental health budget so that we can actually tweak things. When it's not like that, you're not tweaking things. You're dissolving the boundaries that hold things together. They deserve credit for addressing the problem in their glacial way, and they deserve criticism for dissipating the unity of the mental health system at the same time.
So in theory, the notion would be that if you're psychiatrically unstable and you're in the ACI, you ought to be transferred to Ellen Slater Hospital.
That's what I would say is let's open 400 beds right now. I mean, because if you have a serious mental illness, and we've already decided to institutionalize you, we might as well use the opportunity to create insight in the illness, to give you a therapeutic milieu, to arrange for your appropriate and perhaps quick discharge to the community, instead of sitting in jail, growing moss, getting none of that, and being, and then told sink or swim.
Right.
It's been fun having you locked up. Now here's total freedom. Go get in trouble again.
Right. Well, and there's nothing to go to, because if you've got a felonious history, you go out and you can't get a job, you can't get a place to live.
And there's another piece of it. During this generation, we've gone out of our way in Washington and at the State House to make sure we can identify all the scapegoats we can find, so that we can separate them out from the herd, as if this saves money. And all it really does is multiply the problems. It's this idea that of moral superiority and scapegoats among the disabled is it's attractive as a soundbite. It's really ugly as a policy.
Well, we found with our Housing First program that if you're able to find a home for someone, that you reduce, within 1 year we reduced the amount of money that was spent on that person's reactive care from $31,000 and change to $22,000, including case management and housing. So it was much more cost effective to have a person in their own home with supports than it was to have them getting reactive care at psych hospitals, the ACI, emergency rooms, detoxes, things of that nature.
Gee, and that's not even rocket science, is
it? No.
And why aren't we doing that? Remind me. I remember small government, no taxes, leave me alone. Oh yeah, that's right.
Yeah.
And I'd say having a home and having health care is a right. It's called social justice, a very foreign concept in our world.
Right.
So it's good for, I really like your program.
We've got about 140 folks now that are out that we've gotten housing for. And probably close to 90% of them have ACI histories, have criminal justice histories, but we've been able to provide them housing because we provide them supports, and the landlords buy into that.
Right.
We'll take them if you'll answer the phone.
And in fact, something I know about your program is that you actually have a guy in place, paid employee, who goes to the land. If there's a problem, he's a liaison to the landlord day to day. I mean, if there's a 6-pack of broken beer bottles, you guys take a responsibility for that.
Right.
Which is not what every mental health center involved in property is doing on behalf of their clients.
Right. Right. In terms of what's going on now for the Mental Health Advocates Office, what are some of the initiatives that you've been working on?
Well, the large initiatives of the last years, the biggest problem I think still remains that mentally ill people are confined for treatment in emergency rooms, and they cannot get access to primary psychiatric care for days at a time. It's a huge problem. I filed a lawsuit over it, and I'm sorry to say that due to the lack of resources, that lawsuit is kind of dormant. On the positive side of that, I think that the mere existence of the lawsuit has led to some efforts to create non-hospital, step-down, voluntary psych hospitals, psych licensed facilities that have we've added 27 or 30 beds since
the STAR program,
since
for
I
example.
filed the lawsuit. I'm talking exactly about the
NRI's
STAR
program and STAR. Yeah.
Right, and that's a step in the right direction. But it's also a kind of an off-the-books hospital, which, as a regulator, I prefer it not to be off the books. And in some ways, it's a part of this problem of decaying the boundaries of the mental health system. I sort of wish the mental health department would take more leadership in creating stuff like that instead of just leaving private people to go. And I think they should create it. They should actually acknowledge that it hasn't solved the whole problem. In fact, at the heart of this problem is an arbitrary decision in 2001, where the Department of Mental Health announced that they would no longer do provisional emergency admissions to Ellen Slater Hospital when there was no bed in the community. That was the protocol for 25 years. And one Friday night, they just sent a memo around to the state, we won't do this anymore.
Right.
And from that day forward, people were backed up eating ham sandwiches in the utter chaos of an ER. And
for days.
yeah, for days. And the hospitals noticed the utter chaos, and instead of turning to the state government to say, do your duty, they generate $40 million to build a new holding facility for mentally ill people, which contributes nothing to the system and just permits the continuance of bad leadership.